Thank you so much, Tasha. Uh, we have so little time together that we're going to get started even as people continue to join. You can hear me all right? Yep. All right, thank you so much. So Vincent Atchity, I'm the CEO of Mental Health Colorado, and we are very pleased to be co-supporting today's webinar with our partners at the Healing Advocacy Fund. Mental Health Colorado we're a nonprofit, nonpartisan advocacy organization affiliated with Mental Health America. We've been operating in the state of Colorado since 1953, just celebrated our 70th year. And we work to promote well-being, increase access to housing, healthcare, supports, and services, and end some of the discrimination that has long been associated with needing and accessing mental health care. Our mission we describe as promoting healthier minds across the lifespan for all Coloradans. We work at the state capitol and with local communities to pass laws, change practices, and build a movement that will get us to a place where we're effectively using our efforts and resources and intelligence to prioritize the health and well-being of Colorado's human population. We were very supportive. We supportively monitored Colorado's Natural Medicines Act of 2022, which underlies our gathering here together today. And as a consumer-focused advocacy organization, wholly support and corroborate statements in the legislative declaration that prefaces the act, and I'll just read a couple of those. The act begins with a preface that declares that Colorado's current approach to mental health has failed to fulfill its promise. Coloradans deserve more tools to address mental health issues, including approaches such as natural medicines that are grounded in treatment, recovery, health, and wellness, rather than criminalization, stigma, suffering, and punishment. Coloradans are experiencing problematic mental health issues, including but not limited to suicidality, addiction, depression, and anxiety. There's an extensive and growing body of research advancing to support the efficacy of natural medicines combined with psychotherapy as treatment for depression, anxiety, substance use disorders, end-of-life distress, and other conditions. We know that natural medicines have been used safely for millennia by cultures for healing, and Colorado can do better to promote health and healing by reducing its focus on criminal punishments for persons who suffer mental health issues and by establishing regulated access to natural medicines through a humane, cost-effective, and responsible approach. Mental Health Colorado, as part of our National Care Not Cuffs campaign, we wholly support this and other efforts to reduce harms associated with mental health conditions and substance use. Putting these natural medicines out of reach of science through decades of criminalized use and proliferation has created a public health and safety problem that we're going to have to address expeditiously to ensure that the potential good of these strong natural medicines is optimized and their potential for harm taken seriously and minimized. We, as an advocacy organization, monitored and didn't endorse the bill only because our responsible effort to promote health and safety, we had to acknowledge that the process of creating a regulatory framework and a strong foundation in evidence-based therapeutic practice is embedded in the act itself and is ongoing work. There's a lot of work ahead of us as a community to do. Our hopes, we are so excited, as I said, to be working with the Healing Advocacy Fund to create a platform such as today's, which will help accelerate the scientific and care-providing community laying of a strong foundation for evidence-based practice in optimizing individual and community well-being, uncovering the force multiplying potential of these natural medicines, and learning to guard against any force multiplying of their harms. With that, I just want to thank you all for joining us. I look forward to the discussion, and I will pass it back to Tasha.
Thank you so much, Vincent, and really appreciate you taking us back to the language of the law and what is really the core intent of what we are embarking on here in Colorado. So my name is Tasha Poinsett, and I am the Colorado director for a nonprofit called the Healing Advocacy Fund. Our mission is, as you can see, to expand and protect safe, affordable, state-regulated access to psychedelic healing for all who need it. We're a multi-state organization currently with teams in Colorado and Oregon, which are the first two states to legalize a therapeutic access model for psilocybin mushrooms. Our focus in Colorado is primarily to support the policy implementation that Vincent was referencing as we develop the rules and regulations for the psilocybin program. And in addition to that, we also do a lot of work around education with events like the one that you are all joining us for today. So I want to take a moment to thank Vincent and the team at Mental Health Colorado for choosing to partner with us on this webinar series and all your work to make this happen. The Healing Advocacy Fund vision is healthier lives and a healing world, which I think really speaks to the understanding that healing happens not just at the level of the individual, but in relationship with our families, our communities, as well as the political, economic, and social systems that shape our lives. I think Mental Health Colorado does an amazing job of holding that complexity while also identifying areas to focus that have real impact. Our organization has chosen to focus specifically on safe access to psychedelic healing, but I think it will take organizations like ours working together to shepherd this change in our laws forward responsibly, including with strong public education to support the fullest positive expression of what's possible here. So with that, Kevin, if you want to move on to the next slide and pull up the poll. That's a quick introduction to myself and to Vincent, and we will of course be formally introducing our other participants on the call in just a moment. But really quickly, we wanted to take a moment to find out something about all of you who have chosen to join us today. So just asking you to fill out this quick multiple choice poll, primarily focused on your professional background, your intention for joining the webinar, and then familiarity with the subjects. So the reason that we're asking these questions is first and foremost to just inform what kind of content is relevant to you so that we know how to structure these kinds of sessions moving forward. So I'm going to go give a second for folks to fill that in. And then once we have gotten a decent number of responses, we will also share this out so that we get a sense as we start this conversation with who all is joining us today, and we'll all kind of be able to share in that knowledge. So I think while we're letting folks fill this in, I do want to mention before we introduce our panelists, we have a couple of other people joining us on the call. We've got Kevin Matthews, who is really handling all the logistics behind the scenes and is available to answer questions in the Q&A. Kevin was also the co-proponent for Colorado's Natural Medicine Health Act, so he's been a major advocate and participant in this process over the past several years, so really thrilled to have Kevin with us today. And then Kevin, if you just, I kind of want to leave it to your discretion since you're really operating this. When you feel like we have a solid proportion of folks responding, it definitely doesn't have to be everybody. We can go ahead and share out the results from this.
You know, we are at 70%. So
oh my
thank you
gosh.
so much already.
Let's see the results. I'm so curious. Thank you all.
Let's give it maybe like 30 more seconds for the remaining 51 folks to jump in. Full disclosure, this is my first time doing a poll on a Zoom webinar, and it's just fascinating to watch everything come in. Okay. And so I can go ahead and start sharing. So it looks like 54% of our attendees today are licensed mental, behavioral health, or medical professionals. 18% are community health, public health, or health systems professionals. We have 20% with advocacy or nonprofit. 11% government official or staff at local, state, or federal levels. 16% research or education professionals. 7% business professionals, and other is 14%. And then the second question, oops, bear with me. So primary reason for attending today, folks, 73% who want to learn more about psychedelic therapies for mental health, broadly speaking. 57% to learn more about our regulated program here in Colorado for psilocybin therapies. 38% who want to be able to answer their client or patient questions about psychedelic medicines and possibly provide referrals. 26% folks who are considering a license to provide psilocybin therapies or operate a healing center. And in terms of folks who are familiar already with psychedelic therapies, we have 8% who are very familiar, 13% who are somewhat familiar, 32% who have a little bit of knowledge, 30% who don't know that much, and then 15% who really don't have very much experience or knowledge. And then in terms of the Natural Medicine Health Act, okay, this kind of makes sense in the policy landscape. 3% of folks today have a lot of knowledge about the Natural Medicine Health Act, 4% a little bit, 3% kind of, I'm sorry, 20% kind of in between. Let's do that. There we go. You can all see this now, I think, on the screen. 26% who don't know that much and 46% who are really here to learn about the NMHA. So at this point, I'll end the poll. We have 159. And
Amazing.
we can, cool.
Kevin, thank you for walking us through that. And I think, knowing that 70% of you wanted to learn more about psychedelic therapies, broadly speaking, you have come to the right place, and we have some real experts on the call for you. So without further ado here, moving on to the next slide, Kevin, I would love to introduce these folks. So we are incredibly honored to have 3 distinguished professionals in the field of psychedelic research and practice join us today. Each of them has a career spanning decades of impactful work that I won't be able to do justice to during the time that we have together. So I'm primarily going to give them a chance to introduce themselves in their own words, beginning with Dr. Matthew Johnson, who is a professor of psychiatry and behavioral sciences at Johns Hopkins University. Dr. Johnson, it is such an honor to have you with us today. Your contributions to our understanding of the science and therapeutic potential of psychedelics have laid the groundwork for us to be stepping into this moment of profound change and exploration in Colorado. For those in the audience who may be unfamiliar, could you just share a little bit about your professional background and also what draws you in or ignites your passion for this work?
Sure. Thanks so much. That was very kind of you. But yeah, it's been a group effort from some great, colleagues over the years. But yeah, I'm an experimental psychologist by training. That's what my PhD is in, with a real emphasis on psychopharmacology generally. So I've studied all kinds of drugs in the lab: legal, illegal, therapeutic, drugs of abuse, uppers, downers, all-arounders, opioids, stimulants like meth or like caffeine, tobacco, but the psychedelics are the all-arounders, if you were curious. And so I've been doing work with psilocybin and a few other psychedelics going back to 2004, so long before, back when folks told me, that's right when I finished my PhD, when folks said, that's crazy. There's a future of using psychedelics to treat mental health. So it's been a long, strange trip, to quote some famous musicians. And I think, probably the important thing here, and I'll tell you a bit about this in I'll give you a brief overview of the field, but I've done work in understanding the nature of the psychedelic experience, the subjective effects, mystical experience, personality change that comes often from these sessions, therapeutic studies with end of life, cancer distress, major depressive disorder, smoking cessation, so tobacco addiction. And thankfully that work has led to the first federal funding in the United States for therapeutic research with the classic psychedelics since that earlier era in the late 60s, early 70s, since that came to a close. So running a multi-site trial for psilocybin for smoking cessation now. But I'll tell you a bit more about that. But that's my story. So I'll end it there.
Thank you. And thank you again so much for joining us. So next up, I want to introduce Dr. Jennifer Tippet. Dr. Tippet is a licensed clinical psychologist and associate director of psychotherapeutics for Atai Life Sciences. She is also an educator and practitioner with extensive training in psychedelic therapies. Really thankful that you can join us today, Dr. Tippet. And can you share a little bit about your background and what excites you about this work?
Yeah, absolutely. Thank you. It's so good to be with you all today. As Tasha mentioned, I'm a clinical psychologist and I do work for Atai Life Sciences, but I also have a private practice here in Denver where I help people integrate and make sense of psychedelic experiences and other related questions and exploration. I also teach and train graduate students and clinicians, and I'm really here wearing that hat, my clinician hat of having worked in Colorado for 15 years in that capacity. So nothing I say should be taken as representative of Atai or their opinion. Just me. The things I really, gosh, what excites me about this? I think all of it. I think the fact that, as Dr. Johnson alluded to, 5-10 years ago, when you would sort of talk about this quietly in academia, people would tell you you were absolutely nuts and don't say that out loud. And here we are on this incredible webinar with 200 participants. And so that's amazing. And so, yeah, I'm just really excited for the growth in this space.
Thank you so much, Dr. Tippet, for joining us. And last up, we have Dr. German Ascani. Dr. Ascani is a psychiatrist practicing in Denver and medical lead and core faculty at the Psychedelic Research and Training Institute based in Fort Collins. As always, an honor to have you join us. Dr. Ascani, if you want to share a little bit more about your professional background and what brings you here today.
Thank you, Tasha. Thank you. I'm so grateful to be here in this panel. Thank you, Health Advocacy Fund and Mental Health Colorado for the invitation. So I'm German Ascani. I'm a psychiatrist. I've been one for 16 years. I'm based in Denver since 2021. And previously, I've been in California. First, I wanted to start and acknowledge traditional healing practices from all over the globe, from which many of our psychedelic medicine research and practice methods are based. So I didn't want to start without saying that I'm privileged and humbled, inspired personally, professionally in this journey by all the wisdom and information that indigenous traditions have carried for millennia with a more interdependent and harmonious global view. So I feel as a professional that we have missed the mark by not incorporating them into our systems of care. So in my daily work in psychiatry, when I see patients and I consult with health professionals in modalities such as training and education programs, I just, I'm humbled by many forms of knowledge. So my journey started in traditional and biomedical psychiatry, mostly in community mental health for many years, primary care clinics, consultation. And it's something that then started feeling very limited and personally and professionally like stifling. So what's unique and exciting to me about the psychedelic medicine and treatment space is that it really invites a process of genuine relationship and unconditional support for individuals that to me is more along my view of humanistic and holistic paradigms. So in psychotherapy, I really love embracing this relational approach and harnessing this interaction between brain and mind and the structural functional domains with the intersubjectivity. And so psychedelic medicine has like encapsulated all for me in that sense. So I love what I do and feel that in ordinary states that these natural medicines engendered are vehicles of true transformation and growth. And I've seen that, I felt that in my clinical practice for the last 6 years since I've sort of transitioned to psychedelic psychiatry. And so it's an honor to be here, and I love sharing, and I'll share more coming up.
Thank you so much, Dr. Ascani. So with that, we do want to hand it over to Dr. Johnson to give us a high-level overview of the research into psychedelics, including psilocybin, and why it's showing so much promise for some of these challenging mental health conditions. So I believe, Kevin, you might need to give Dr. Johnson. Oh, we are set. All right, get away.
Kevin and I have been chatting on the text, and we're ahead of you, man. We're all set, I think. If you're seeing something that looks like a title screen, very cool. So yeah, I'm gonna also set my alarm because I was given the challenge of 10 minutes, which I'm a man of my word, so I've set my timer. So we're all going to hear it if I go over. So let's see. Psilocybin therapy for mental health. Let's see. Hopefully you see a screen advance there. I do have some, by way of conflict of interest, I do advise a few companies that are developing psychedelics along the FDA pathway, although nothing I'm going to talk about today directly involves the work of those companies, but just wanted to share that. Of course, talking about psilocybin, most people probably already know, but it's the active agent in over 180 species of mushrooms. Pharmacologically, it's considered a classic psychedelic, so in a different category as MDMA, but in the same category as LSD, DMT, mescaline. And what combines those in terms of the way they work is that they all activate what's called the serotonin 2A receptor, so a particular subtype of serotonin brain receptor. And the evidence suggests that the sacramental use of psilocybin is not only historic but prehistoric. In fact, the oldest evidence that I've seen suggests on the right a cave painting depiction showing, or suggesting, I should say, sacramental use dating back about 9,000 years in Algeria, northern Africa. If you can't see their heads, they're kind of giant mushrooms, and they're dancing around with mushrooms in their hands. So we're in the so-called psychedelic renaissance. There was this area of real excitement in the 1950s through the early 1970s, where primarily LSD was being explored. But just when things were really getting started, the rug was pulled out when really public sentiment turned. And then there were the dark ages of a few decades when there was really no human research. Though there was good advances in animal research, there was no human research for decades. And then what I'm plotting you here on the screen is sort of the beginning of the so-called psychedelic renaissance, or the age of enlightenment after those dark ages, where we see this exponential-like increase in interest in psychedelics. I'm plotting you the number of scientific papers with psychedelic or hallucinogen in the title or the abstract of the paper. So the trend continues to increase. I always like to, whenever I give a talk, I like to at least mention that these are powerful tools. There are risks. I made that a focus of my career. I don't have time to get into those today. The bad trip is a real thing. And there are other risks, but I could share this or refer these papers that I've published over the years focusing on what those risks are. But importantly, we know what the major risks are, and we have ways to address those clinically that I think really ultimately through preparation, guidance, and follow-up care integration, that I think really creates a very favorable risk-benefit ratio compared to much of what we see in the practice of medicine or clinical psychology. The studies that I'm going to tell you about very briefly all had the same psychedelic therapy model that dates back to 1959, the first time it was published in the medical literature. And so essentially, the person is prepared about what the experience might be like. During the session itself, there's not a lot of talking. It's largely introspective. That's why they're wearing eye shades. They're wearing headphones through which music is played. The staff, the guides, the therapists, whatever you want to call them, that are there with them are largely there to support them if they should have anxiety, and help them work through the experiences I'm showing you here with a mock participant. So now I'll go kind of through just a bird's eye view of some of the major studies in the field. The first modern era therapeutic study was a colleague and friend, Charlie Grove at UCLA, that published with sort of a modest, about half the dose of the high dose that's typically used these days, a modest dose of psilocybin to treat end-of-life cancer patients that had anxiety and depressive symptoms, and found evidence in this small pilot study that of reductions in anxiety and depression even 6 months later, and again at a pretty modest dose. But that paved the way for some other studies, including the largest study on this topic I conducted with colleagues at Hopkins, published in 2016, with 51 patients. And I won't belabor all the details, but just on clinical gold standard measures of clinician-rated depression and anxiety, we found large clinically meaningful reductions into the non-symptomatic level region on average after the first session. It was a randomized study. Dose was everyone got a high dose and a low dose, but not only did the data show that 5 weeks after each one of after the high dose session, where there's a dramatic plummet in depressive anxiety symptoms, that's impressive enough. We saw at 6 months that same those same results, virtually unchanged, and this is from a single administration of a high dose. So it's not just in our hands, virtually identical results with a complementary, different experimental design by our good colleagues at New York University, published at the same time, so large reductions in anxiety and depression. Now moving outside of cancer, the first work with just depression, what we know as major depressive disorder, published by my colleague Robin Carhart Harris when he was at Imperial College London. So in this small pilot study with 12 patients, they found that psilocybin sessions resulted in long-standing reductions in depression that were apparent up to 3 months later. First randomized study I conducted with colleagues at Hopkins. It was a waitlist control, so people were randomized under open label conditions to either get the treatment 2 sessions, either relatively immediately or after waiting a couple of months. And we found, as I'm showing you here, large reductions in another one of these gold standard depression inventories, reductions in depression in the treatment group, and then no change in the group that was simply randomized at that time to delay their treatment. That group ended up seeing similar reductions in depression once they were crossed over and received the actual treatment. Then bouncing back to the other side of the Atlantic again, Robin's group at Imperial published this comparison to escitalopram, which people know as Lexapro. It's one of the commonly prescribed and approved in many nations, SSRIs. On the primary outcome measure that was pre-designated for depression, the results fell short of a statistical difference between psilocybin and escitalopram. But I would note that on the primary outcome, that at every single outcome point measured, there was a trend for psilocybin to do better than escitalopram. And again, escitalopram is an approved SSRI known to help, at least to some degree, for depression in multiple nations. So I would say very promising results with a relatively small sample, also found in another of other outcome measures aside from the primary measure. Clearly statistically significant results, including what I'm showing you at the bottom on this measure of well-being, kind of hinting at there's a little more than just treating the symptoms. It's sort of a wholesale life change. Maybe we can talk more about later. But then the largest study of psilocybin published to date, published within the last year, Goodwin and colleagues published in the New England Journal of Medicine, a comparison of high dose to moderate dose to really a trivial dose, really an active placebo, you can consider it, of psilocybin, and found, similar to the other studies, long-standing depression apparent up to about 3 months, with a really nice, I would say, dose-related effect with significant results at the highest dose, with statistically significant results at the highest dose. And then recently, a study that I was a part of, published in JAMA, psilocybin under double-blind conditions compared to niacin as an active placebo, so to speak. Again, and there were 60-some people in this study, large reductions up to 43 days later in depressive symptoms. So, and then very recently, and I should say, actually, I'm going to be joining the Shepard-Pratt group come March. I'm really excited about that. But this work done by my colleague Scott Aronson at Shepard-Pratt looked at bipolar 2, an indication we normally avoid and exclude from this work. So didn't instigate any manic phases, which is typically the concern, but saw large reductions in depression in this group. I'll very quickly go over the smoking in my 1 minute left, or the addiction work. I've had a line of research helping people quit smoking. This was a pilot study. This is basically a breathalyzer for smoking. After the first psilocybin session, this pilot study, very large results. You don't have to be a stats whiz to see large reductions there. 60%, even 2.5 years later, were still biologically confirmed as smoke-free. Another way to look at that under the most stringent lens, continuous abstinence. This means a year later, people hadn't even had a puff. You see our results on the right compared to the best treatments currently approved in the literature, both psychotherapy and medications. It was a pilot, so the question is this worthy of follow-up? And the answer was yes. So we've been doing that. We haven't published it yet, but we've recently finished this randomization to 82 people to nicotine patch versus a single psilocybin treatment. And I'm showing you the results here from about 61 patients where a year out, 52% biologically confirmed abstinent compared to roughly doubling what we get with nicotine patch, which, by the way, these are very good results compared to the scientific literature for nicotine patch, but nonetheless, roughly doubling it with psilocybin. So stay tuned for the most up-to-date results that we published. And that led to the grant that I mentioned. We're now doing a multi-site study. Very similar line of research my good colleague and friend Michael Bogenschutz at New York University has done, first publishing a pilot showing reductions in drinking days with psilocybin sessions. Most recently published this JAMA Psychiatry paper with some biological verification with hair analysis, also finding reduction in drinking days following psilocybin treatment. So that is all, just thanking colleagues and funding agencies. But with that, I've more or less kept to the 10 minutes. So I'll hand it back to you.
No, that was incredible. Thank you so much for walking through all of that. And sorry for the sort of arbitrary time limit there. But really incredible. And I want to just kind of, I think, highlight a theme that I hear coming up over and over again across these studies, which is actually looking a little bit down the line, months after the actual treatment and still seeing the results. So I was just wondering if you could just comment a little bit on that piece.
On the long-standing nature of results, or
what
maybe
we're thinking, yeah, sort of the timescales of the impact from these treatments and the differences that we're seeing potentially relative to other forms of medication or other psychotherapy.
Right. So the big paradigm shifting thing is even the mode of treatment is different, right? The typical thing with psychiatric medication, you're treating symptoms, you're taking a pill every day, sometimes once a week, but typically every day, treating symptoms. The real different thing here is that we're having, and it's in the literature and the therapeutic studies, it's ranged from 1, 2, or 3 sessions typically. But from those one or a few sessions, we're seeing results, decreased smoking, decreased depression, decreased anxiety. 6 months later, a year later, the longest I think that's been reported is a follow-up to the NYU study at about 4.5 to 5 years later. So these are for the stats nerds out there after the crossover. And so it's not the cleanest way you want to look at the data, and unfortunately in the cancer work, not everyone is with us anymore because of the nature of what we're studying. But yeah, you see it. And after many of these studies, like we had the formal follow-ups, but I'll tell you what, like we still get people say, it was 8 years ago when I had my session to quit smoking and I'm still abstinent, no, I mean, just people will keep in touch and like let you know how long-standing this has been helping them in their life. So it really is that long-standing change. And I know we'll talk about mechanisms later, but quickly, I think the key is that we're not just treating symptoms, we're bringing psychology back into psychiatry. We're actually treating the roots of these different disorders. People learn things. They have a story to tell you. They start changing the way they're thinking and behaving in their everyday life. And that has a feed forward into their life. They're establishing a new normal. So that's why I think we're getting these differences. We're sometimes confused. Like, how can a medication have its half-life is only like 6 or 10 hours, whatever. How could it have an effect months later? It's like, we don't ask those questions about psychotherapy. Good psychotherapy, we know you can go through a 6-week course, and many times when it works, yeah, you're seeing differences years later because people have changed.
Amazing. Thank you for elaborating a little bit on that. And I agree, not having a clinical background, but just learning about that, it's very exciting to know that that's possible. So I think we are going to shift gears a little bit here before coming right back to the research. And for that 40-some percent that want to hear more about Colorado, I'm going to ask Kevin to bring back up our presentation here, and we're going to share a little bit with you about Colorado. So as many of you may know, in 2022, almost 1.3 million Coloradans voted yes on Proposition 122, making Colorado the second state in the country to approve a state-regulated program for legal access to psilocybin therapies. Oregon was the first state to take this step with passage of their psilocybin services measure in 2020. And Oregon actually launched their program last year. So in the past several months, we've seen over 900 people have received access through Oregon's regulated model, which is pretty incredible if you think about that in the context of the research, that with these state models, we are opening up access a bit more broadly than we've seen the pace in the clinical trials. Colorado is still in the process of, somehow it looks like the presentation disappeared there, but I'll keep going. So Colorado is still in the process of rulemaking for our regulated program, with the launch of the program slated for next year. And in Colorado, we have the great benefit of learning from Oregon with our team at Healing Advocacy Fund. We're supporting implementation across both states, so we are uniquely positioned to ensure that the lessons learned from Oregon can be integrated in Colorado in real time, which is a pretty amazing opportunity to be a part of that process. Kevin, are we able to, do you know if we can get that? I'm not sure what's going on there.
It's coming right back. I apologize. It's coming right
No,
back.
you're good. That's all right. I'll just continue. So I want to give you some details about the specifics of the regulated access model in Colorado. It's a therapeutic access model for adults 21 and up to access psilocybin mushrooms, requiring support from a trained and licensed facilitator both before, during, and after the psychedelic experience. And as I mentioned, we have a two-year rulemaking process to actually set up the regulatory structure, which includes establishing licensing for these trained facilitators, as well as healing centers, and cultivation, manufacture, and testing of the mushrooms themselves. One key thing to note is that this program will not require a diagnosis or prescription to receive access. There will be other components in place to support safety, which I know Dr. Ascani and Dr. Tippet are going to touch on in the next section. And then one last note, we're starting with psilocybin mushrooms, but there's the possibility for state regulators to add additional natural medicines at a later date. So that's why you'll kind of hear us going back and forth between natural medicines and psilocybin. But for purposes of the current regulated access model, it is specifically for psilocybin mushrooms. I'm going to move on to the next one there. A couple things to note that Colorado's program is not. This is not a retail sale or dispensary model, so nobody will be able to go in, purchase psilocybin mushrooms, take them home, and use them without that supervision that was mentioned earlier. This is not access for minors, so it remains illegal to provide mushrooms to anyone under the age of 21. Similarly, activities such as driving remain as illegal as they were before passage of Proposition 122, while under the influence of mushrooms. And anyone that's participating in one of those therapeutic sessions needs to work in advance to make sure they have a safe transportation plan home after the session that doesn't involve them driving. And then lastly, the program does not include synthetic forms of these substances. So we are talking specifically about psilocybin mushrooms in their cultivated or fruiting body form. So with that, I want to hand it over to Dr. Ascani and Dr. Tippet to dive a little bit more into what is this therapeutic model that we are implementing in Colorado. So as I mentioned, there's some specific requirements in terms of what this process is going to look like. So I think starting off with Dr. Ascani to speak a little bit of what pieces like a safety assessment can look like.
Yeah, sure. Thank you. So let me start a little bit by pointing out this amazing groundbreaking research, increasing our body of knowledge, our interventions, and how they can translate into actual clinical practice. And also say that it's not a panacea, right? It's working well. It's for a specific population sample under particular control conditions, which is our scientific model of how we test things. It has great strengths, and it also has its limitations. For example, the psilocybin research that Dr. Johnson presented, it's done so that you can pick a particular population under controlled conditions for a particular problem or pathology. So it sheds a lot of light on that specific sample. However, it doesn't address sometimes what we see in the real world clinically, complexities of people's lives, cultural, societal factors playing into their depression and personality dynamics. So I feel like the research is going to keep forging ahead and shedding some light on these more real world entities that we're trying to see and apply these methodologies to. And so the research because they're asking a particular question, it doesn't mean that it's exclusive of the therapeutic use of these substances for other things, right? The bottom line is that it's done in a safe way. And so we know that psilocybin is safe. It's safer than medications I prescribe daily for patients. We know it's got a low risk of abuse, it's non-toxic. And so as long as proper screening and safety is in place, this model, which is not the only model, it can be a safe process for people to undergo. And so I think this is where the regulatory model is a little bit different in that it can address pathology depending on screen assessments and safety, but it could also allow access and flexibility to even address personal growth, for example. So we're not pathologizing, and we're giving people access to correct things in their life that may not necessarily amount to pathology as we define it in the DSM-4, for example. So when it comes to screening, the bottom line is you have to keep participants safe. You have to keep vulnerable individuals and populations that may not be appropriate to undergo this process. So, for example, in this 2-year rulemaking process under the law, there's a lot of thought and effort that's going into how to screen appropriately individuals that may be at risk. So when we do that, we start assessing for cardiovascular conditions, unstable hypertension, neurological conditions, things that we know put people at risk based on the data that we have. Dementia, right? Inability to consent is a big ethical consideration among other ethical considerations in this process. So we want people to be safe and have safe screening. So in the physical side too, there may be people that need that have disabled or less able bodies that may need help transferring from couch to mat to bathroom. And so it warrants careful planning and assessment. So the real world practice and clinical practice is not the laboratory, and by doing it in a safe way, we'll learn a lot more. So for example, if someone comes to me, if I'm doing a screening, I would make sure that a psychotic process is not happening. They don't have a diagnosis of schizophrenia, schizoaffective disorder, manic phases of bipolar. As we saw Dr. Johnson present this very recent study, the bipolar depression. So a depressive phase may be appropriate as long as we screen with the necessary items. Active suicidality is one that we want to screen for. We know that personality disorders exist in a continuum. So not that this is exclusionary, but it may be a red flag to further assess and look into this individual's personality pathology, for example. So I would say that we are carefully determining and coming to an agreement on what is an absolute contraindication and what may be a relative, just to come up with this tier system that's being developed in the context of someone's life's condition, plan for this psychedelic use, and how do we exclude risk, and how do we safely provide an environment or a provider that may have necessary, like more skills or a facility to address certain needs that people may have. So that's more like in the diagnostic category, physical, mental, and it's not exclusive what I'm mentioning here. There's a lot more. It's just I want to leave time for Dr. Tippet. One more thing I wanted to mention is medications, right? People are taking medications, supplements. So we talk about drug-drug interactions. What are red flags? What are contraindications? One thing that pops up in the literature is, for example, lithium appearing to have an increased risk of adverse reactions and seizures, serotonin toxicity, etc. So screening for that. Sometimes what the medications that individuals are taking kind of give you hints as to their background. They may not have insight into their background of psychosis. Almost by definition, there's a lack of insight in a thought disorder. So we want to make sure that if we're carefully seeing that someone has polypharmacy with antipsychotics, SSRI, various psychotropic medications, that this may affect their ability to participate. And it may also affect, if they are able to participate, how sensitive they are to psilocybin, how diminished or accentuated a response would be, and how it could alter the qualitative effects. Medications such as benzodiazepines pose risk of withdrawal seizures if someone's not taking them for a particular length of time ahead of a session. So all these things become really important to safety and how we allow individuals to access and undergo the process. So there are many, many things that I didn't talk about. These are just some of the highlights. And so the bottom line is with safety is that not to exclude and be totally exclusionary, but just be assessing and have different entry points for different individuals that may benefit from treatment, yet may need a higher level of supervision or observation before, during, and after. So I think I'll stop there and hand it over to Dr. Tippet. I'd be happy to answer questions in the next segment.
Thank you so much, Dr. Ascani. And yeah, Dr. Tippet, I would love to hear a little bit more, I think, as well experientially about what this process can kind of look and feel like.
Yeah, absolutely. How much time do I have, just so I know how fast to talk? Am I good? Do you want to? Cool. You know what, that slide that you all have, Kevin, about the breakdown, that might be just a helpful backdrop. And yeah, that'd be great. And Dr. Ascani, I'm really glad that you touched on some of those safety risks. And Dr. Johnson, you also mentioned at the beginning of your talk around assessing to make sure that someone's an appropriate candidate. I think there's a lot of really great excitement about psychedelics, which is amazing, but it also can lend itself to a bit of hyperbole in this field. And we get a lot of silver bullet magic wand waving, this is going to cure everybody. And I think we as clinicians really need to be mindful that we're helping people make good decisions for their individual bodies and minds and brains. So that being said, when we sort of look at the way that this has been structured for Colorado, and is structured in a lot of different places, we've pulled from places, clinical research at Hopkins and other companies, as well as things that have been done for thousands of years in indigenous populations. And this is really what we think are the important components when we start to put this together. The specifics of each of these really vary among practitioners and different settings, as Dr. Ascani kind of alluded to, but really important that we hit these time points and really ensure that people have some of this wraparound model. And I won't go into, this is what you should or shouldn't do, but maybe I'll just touch on some key points in each of these timeframes. So when we talk about preparation, we're really talking about getting someone to a place where they feel like they know a little bit about what's about to happen to them. As with anything in life, we all do better when we think we have a bit of a sense of what it's going to be, how it's going to go, what we should do, what we should expect. As human beings, we're just wired wired that way. So this at the very least is like education. This is what you're going to take. This is what could happen. There are also 3 conversations I really feel are important to have explicitly in this preparation phase. One of them is social location. So that's your race, your ethnicity, gender expression, sexuality, socioeconomic status, anything about your identity, their identity, how that might interact in the room. That should happen before the administration session. I also like to ask people about religious, cultural, or spiritual beliefs, practices, things that might come up. And then thirdly, touch. This is a hot button issue among psychedelic practitioners. You'll get a lot of people with a lot of big feelings, but important to have a conversation about touch, how it would happen, when it would happen, and to get consent before somebody takes any sort of medication, have that conversation ahead of time. For the administration session, Dr. Johnson showed a really nice slide of, kind of the eye mask and the music, and that is definitely how it's been done in a lot of research settings. In other indigenous settings or other parts of the world, that might look really different. And we don't have any research that says one is better than the other, or you should do this, you shouldn't do that. I think the things that are key to remember in an administration session is that people are extremely impressionable when they're on a psychedelic. And so we really want to be careful about what we say or what we imply. For practitioners especially, we often want to get someone somewhere or help them have some insight. That usually is about us and not about them. So there's a lot of really good trainings that kind of address how to manage yourself in the room. Also, to touch on the fact that all administration sessions are not rainbows and butterflies. Sometimes they're lovely and people just have the greatest time. And sometimes really challenging experiences come up. I think, Dr. Johnson, you said the bad trip is real. People can really struggle. And so having an idea of how you're going to manage that, what that's going to look like, what sort of support you need in that space, also really, really important if you're going to sit and do this work. And then integration. I always talk about this as this is where the rubber meets the road. This is where all of these great insights that you might have had during the session can really be applied to your behavioral change, what you do every day, how you see things. What I really hear people talk about is just having some space. I saw the same problem I always have. I saw the way I always respond to it. And this time I saw there was a different way and I got to choose. So it's often not that you kind of walk out of these sessions a totally different person with a totally different brain. It's maybe these little shifts that just give you some space to do something differently. And those little moments really add up and can be capitalized through therapy, coaching, whatever works best for folks.
Thank you so much for that really
beautifully
captured explanation of this complex process.
60-minute,
I know, amazing. And I just want to say, I think it gives me a lot of reassurance, and I think the audience will love to hear too, that it's incredible that we're in a moment in Colorado where people like Dr. Tippet and Dr. Ascani, who are, based in Colorado, are informing this process and bringing this depth of knowledge and experience that they have to inform the state regulatory process. I think that we are going to be so much better off for your efforts, and I just want to thank you for that as well. So, and acknowledging that you are also too amongst literally hundreds of people participating in this very collaborative, multifaceted effort. So, pretty amazing. With that, I want to, turn it over and share, Kevin, this film that it's a short film that Healing Advocacy Fund has produced in Oregon that really, I think, brings to life some of the pieces that we've talked about here. And before we get into this, I spotted a comment in the chat about people with lived experience and representation in these kind of forums, and that's super important. So I want to acknowledge that. And the way that we've structured this particular series, this is the first of 4. So the next session is actually going to be all people talking about their lived experience. And we're going to incorporate further discussion of the research that ties into that. So really hope you all join us for that as well. But we did want to incorporate some of that piece here as well. So this film is also trying to get that piece here in this first session. So without further ado.
I believe that I was raised to be an invisible child in the home. not to have any needs, not to want anything, not to cause anyone else to have to change anything they're doing to recognize or validate or see me as a child. I'm not allowed to feel. And if I do feel, I'm not allowed to convey. This is not a safe channel for me to talk about it. And I didn't really understand it, and I still don't, sitting here 42 years later. The 8 years that I was in the Army, I've found it aligned with my emotional way of living. If you are needy, then you're marginalized. I'm in grad school to work with veterans, counsel mental health. The reason I'm getting into counseling was my wife was sick. She was bowling on a Wednesday night, and Saturday she was in the intensive care. Had septic shock, and the next 6 weeks were spent in the hospital. That challenged me to get counseling for the first time. I found that counseling experience very beneficial. I view this psychedelic therapy as another version of what could be helpful. I don't have the time that I thought I had, and my wife almost didn't have. I definitely want to be the best that I can be without hesitation.
Congratulations, Bill, for being one of the first in the country, possibly in the world, to participate in the legal use
That's
of
a key word, right?
psilocybin.
Yeah.
When you arrive tomorrow, we'll pretty quickly head back into the session room, get you settled, and then you'll receive the medicine. When we look at this kind of medicine, it is a dilator of experience. And so eye shades on really helps going in. This is a process of surrendering. Your job during that time is to be, as much as you can, a curious observer. So with the understanding that difficult things can and will arise, but you are invited to turn towards that.
So I'll share probably the biggest thing that came up for me during the session. I was given a choice to come back or to stay.
What did that mean to you?
I felt like the choice to stay was choosing myself over others. And the choice to come back was to see or reward or love the people back that love me. My wife is very important to me. She is the rock in my life, and I decided if I can, then I want to come back and be with her. And at the same time, I also got to understand, here's what you're doing that you may or may not know that is jeopardizing what you just identified as being very valuable. And that's tied to my 8-year-old self and shutting down emotion and pushing people away and not being my full self, which was the intention. They say you don't know what you have until it's gone. In my chance, that's not true. I got to see what I have, but it's not gone. So I cheated the system, and that's absolutely cool. I asked my wife if she would like to know about it, and she said, yeah. And so we just started talking, and we talked all night. And I told her that I had the choice to stay or to come back, and I broke down. I haven't done that in a long time.
How did that feel? Gives me chills.
Are you glad you did it?
Yeah, without a doubt.
So what did it mean to you?
It was a lot. Because now you can see some things you didn't know. And I see how I've been hurting others, and how I can help, and how I can make it better, and how I can live a better life. I never thought that was possible. I'm just so fortunate that we are able to see the value in this as a medicine, and the science that is happening around it, and the way that our culture is kind of being open to and curious about this medicine. I welcome that. I don't know what the future holds, but I can't imagine it being better than what I had, but it's already so much richer. In the past 2 days, I didn't know that was possible, so who the hell knows where it'll go. It's really cool.
All right. Well, thank you for sharing with us and hearing a little bit about Bill's story. And just a quick comment on the process of making that film. You know, we only had the chance, our team in Oregon, to capture 2 stories of all the people going through the program in Oregon. And I think it's sort of a metaphor for the experience of psychedelic therapies itself, but you don't know exactly how that's going to unfold. So really, I think the team there did a beautiful job of tracing Bill's story and recognizing that this is a unique process and journey for each person. So with that, and as we kind of move forward into the last segment of our session here before opening it up to Q&A, I want to open up a little chance to discuss what are some of the mechanisms of action here. And I want to ask this question recognizing that we are still deep in the process of scientific inquiry to better understand why people are experiencing such profound benefits in some cases. And so, you know, feel free to take this in the direction that speaks to you from your professional background and experience. And it's all right to have kind of a range of perspectives represented here. So I think starting with you, Dr. Johnson, if you want to jump in and speak to that question a little bit.
Sure, thanks. And yeah, beautiful video, by the way. Well done. I'm so glad for that guy. The mechanisms, like, so that's such a big picture question. It's like, so there's the immediate brain effect, you know, mechanisms. We know a lot about that. In fact, a lot of people may not realize we know more about the acute effects of something like psilocybin than we do about SSRIs. You know, there's still a lot of mystery. It's very delayed effect regarding like receptor regulation and with the SSRI. So we know what, as I mentioned earlier, the subtype of serotonin receptors activated. We know at another level of analysis in the brain that there are dramatic changes in the way in which the brain communicates with itself. This is when someone's having a psychedelic experience. So this is called brain network dynamics. You pick up on it with something called resting state fMRI, but it basically means that the synchronization across the brain, the compartmentalization of the brain, you know, there's very much this compartmentalization of function, like, oh, this area does this, it's kind of offline from the other areas, this area does this. So there's both kind of an integration of areas that they're synchronizing, which means more communication between them, in areas that don't normally communicate so much. And that's probably related to not only some of the synesthesia and perceptual blurring, but the insights, the looking at oneself from a different perspective, this radical change in perspective taking. And but then you also have other areas that do communicate more with each other on a normal basis, but then now they're decoupled. They're not as communicating so much. So there's things called like the salience network and the default mode network. So these kind of local networks. So it's sort of like a scrambling. It's like when the internet comes into society, it's like you used to talk more to your neighbors and, you know, barely to someone across town and not at all to someone across the world. Now the internet comes in, for better or worse. You know, like there's some worse too, you know, it's like now you might not know your neighbors. I encourage you to know your neighbors if you can, but you might not know your neighbors at all, but like you're best buds with someone in Pakistan because you share a hobby and you got to know each other online. So that's kind of like the internet in that model in terms of, but those are just acute mechanisms. And I've just talked about biology. I've already said before, like there's a psychology, which is probably the more, it's not one or the other. I view this as 2 sides of the same coin. And so it's just like, what's the more appropriate lens to address the particular question? I think we have a lot more, despite everything we know about the biology, I think we know a lot more about the psychology. You know, there's perspective taking, there are insights, there are changes in life priorities. And that's just kind of in the immediate and in the aftermath of the sessions. There's probably, and this is more at the forefront, but increases in executive function, a fancy way of saying having more agency of your life, to be able to like execute, make decisions, not just be on autopilot, but to say, no, I want to do this and I'm going to stick to it. I'm going to do that, rather than just sort of going on. We're all on autopilot to a lot of degree during most of our lives. We couldn't function otherwise, but it's kind of bringing more of the right decisions and behaviors in your life and ways of thinking into away from that autopilot and bring it more into volitional control. So there seems to be something like that. But then again, I mentioned this earlier, briefly, it's like that radically different acute experience probably leads to these changes in life, which is probably why you're not going to get, sometimes you get, and I've done surveys on this, like sometimes people take these things just for fun and they have this eye-opening experience and they say it's changed their life. They stop drinking, they stop using cocaine, etc. Because of this experience. But, I think you're far more likely to have a therapeutic impact if you go in with a therapeutic intent, and even more so than if you have therapeutic support from someone who knows what they're doing with this stuff. So, I think it's another aspect biologically, and I'll give myself one more minute because I don't want to there's just so much, it's such a big question, but we know from rodents, we don't know this for sure in humans, but there's incredible forms of neuroplasticity, and a fancy way of saying different ways for brain cells to be flexible. So the forming of new branches between neurons, brain cell, a type of brain cell, forming new branches, new connections between brain cells, and even some evidence for the birth of new neurons, neurogenesis. And so that seems pretty remarkable in rodents. We don't know if it's happening in humans. I think it probably is. If so, that may be part of this kind of plasticity behaviorally, this propensity for potentially accelerated learning, which is not only consistent with therapeutic effects, but we can keep in mind, the CIA was studying psychedelics as brainwashing agents for a reason. There was some success there. Charles Manson really used LSD as again, to brainwash his cult followers. So that's all consistent with this idea that there is this general plasticity. So you make something into a more moldable form, and with therapeutic intent and in the hands of people that help, you can create something beautiful and improved. And in horrible hands and with the wrong conditions, things can go worse. So I think that general model, that plasticity is probably part of the overall formula. And it's not one of these things or another. It's probably a lot. It's probably not a single thing. It's a double, triple, quadruple, quintuple whammy, to use scientific lingo. So that's my take on it. And again, it's like psychotherapeutic process, because you're actually learning something and starting to change the way that you're living your life, and that becomes the new normal long term. But I'm curious what the others have to say.
Yeah, I want to give us a chance for you to jump in.
Yeah, I'll jump in really quickly. I want to go back to what you had mentioned earlier, this big paradigm shift. So it is a paradigm shift because it's both the intersection of the biology or the molecule and our psychology as humans with experiences in the world and learning and unlearning. So it's like using this process. So the FDA is for the first time looking at this question of approving a therapy that has both the medicine component and a psychotherapeutic component. And so some of the mechanisms or changes are happening at that level. And the science is beautiful, it's elegant. I don't know that people feel it. So when I explain it to people, how will this work, is like, we heal in relationship. That's the other big piece, in relationship to the other or the group that you're participating in this process. You heal in relationship to yourself and finding yourself, your connection back to that, to your source. You heal in the context of larger cultural and natural forces that really affect our lives and cause a lot of frustration, grief, trauma, displacement. And so there's a realignment of a lot of that in this process, which has to be carefully crafted through preparation, the session, and then the integration, which is the learning, right? This is the learning we're talking about. other way that I explain it is you're priming the brain for learning. So then what content are you going to put in there for learning? The psychotherapeutic intent, the what happens after, immediately, post, weeks, months later. And so people have the immense capacity for change and transformation, and that doesn't only happen with psychedelics. So there's something that's also clicking at another level that we are embracing, bringing in this paradigm back of like interdependence and how we're all one more thing I want to say is that severe depressive pathologies, traumatic pathologies, really isolate us. So is this connection back to all those things and away from siloing as an individual that's suffering and withering in the world. So it's really embracing working together, working with someone, and really like finding a connection to yourself as another level.
Yeah, I would just piggyback on all that's been said. I think all of that, from the neurobiology of it and the interconnectedness, is huge. And there's also, I was just thinking about, I was reading this paper the other day about the impact of the experience of awe, like how it impacts overall well-being and satisfaction when we as humans experience something that we think is like awe-inducing. And really what you hear a lot when people have these experiences, yes, their brain is doing cool things and maybe there's new neurons, and we on this call love that. But for them, a lot of the time, it's this experience of awe and this, oh my gosh, what was that? And can I have more of that? And that is what I hear people drive the behavioral change, is I want to be in more in alignment with that. I want to understand that version of me more. I want to understand that version of the world more. And whether you have like a specific religious or spiritual, framework, teaching, whatever, that sort of inherent like, oh, wow, really, I think drives so much of the change that we see in people after they have one of these experiences.
Thank you all for sharing your thoughts on that. And yeah, I think that there's this little piece that connects to what you just shared, Dr. Tippet, that I also think connects to what we heard in the video from Bill. There's this moment when he talks about this sense of not being allowed to feel. And I think for me, looking at my personal experience, that's something that's come through really clearly, that these medicines have the potential to open up this capacity to just feel the things that we need to feel. And in my own experience, that's come through really clearly. Just I'm allowed to feel and letting that, pass and move through. And so I think there are so many different pieces to this. We could continue to talk about this probably for the rest of the day, but we do want to move on over to the Q&A. I guess really briefly, Kevin, if you want to throw the timeline up on the screen, do you feel like we have time for that? This is coming back to Colorado after we've gone down a few rabbit holes. So this is the timeline really quickly for the regulated access program in Colorado. They're beginning to accept applications for licenses at the very end of this year. So essentially next year is going to be program launch. And I just want to mention one thing. So we have geared this call primarily towards licensed clinicians. You do not have to be a licensed clinician to be a trained and licensed facilitator in this program. So this is potentially more broadly applicable than just that. I will also say that I think we've touched on a really core theme of why we've wanted to host this webinar series, which is that it's not just what happens in the psychedelic experience itself that matters. It truly is the support before and the support after. So to the extent that we have a mental health and healthcare community in Colorado that's aware of what's happening, I think you're all going to be better prepared to support patients and clients who are seeking out this option as it becomes legally available. So again, just thank you for taking the time to be here. And with that, we are opening it up to the Q&A. I guess we didn't really talk in advance about how to structure this in terms of opportunities for people to actually raise their hands and come on and speak. I'm gonna take a quick look here at the chat. We've got a bunch of questions and some of them have been answered and some have not. Here's an important one. Actually, I think this is worth talking about. So there appears to be a real potential risk for diminished effects of psilocybin. For example, serotonergic antidepressants can do this. Many people approach this opportunity and experience with high hopes for healing. There's a risk for significant loss of hope in these folks, which can be harmful. Anyone have any comments on this?
Well, at first it sounded like maybe the questioner was referring to tolerance, and actually answered one of the, on the chat question about, you do get tolerance for psilocybin for about a week or two, but it's one of the reasons typically people don't use on a daily basis, one of kind of the anti-addictive mechanisms, because someone has to kind of basically double their dose if they want to use on a daily basis, because there's such a high rate of acute tolerance. But they're really, in terms of whether there is sort of what you would call more behavioral tolerance, like maybe it's having the same pharmacological effect, but because one is kind of just psychologically used to the effects, do you get less bang for your buck like later on? I haven't seen it in the studies that I've conducted, and I've conducted studies with up to 5 different sessions, or I guess I should say 4 active sessions of psilocybin, and and sometimes often it's the opposite, like where someone can dive deeper. It's almost like on the first session they're getting used to the wild rapids. This is all metaphor, and it takes some while, and then they kind of reach still waters later in the session, and like in their next session, now they're willing to kind of dive in more deeply and get past the confusional state, and so and kind of know what they're dealing with. So now in terms of the Wild West, so to speak, just in terms of people with no, and I'm not just saying in, the FDA approved clinical studies, but just, when someone doesn't have support, when they don't have the right intent, when they, they don't have the safety guidelines that are typically at play in the clinical research and in clinical practice when it's done well. Like, yeah, there's some evidence that people, and I've helped to publish some survey research like this, like, yeah, sometimes people get worse when they use psychedelics. Frankly, knowing and seeing what I've seen about the powerful effects of psychedelics, it'd be impossible to imagine that a tool with that kind of power could not have the potential to make things worse depending on the circumstances. I mean, the same knife that can stab you in the alley is the one that can, same basic tool can pull out the tumor and save your life on the surgery table. And so it's in that category of a powerful weapon. And some people, so, we do know certain things, we need to expand the scope, but it appears that at least for some people with psychotic disorders, that they can be destabilized from this. There's anecdotes to the opposite, but we know enough if that's even, maybe that'll be explored in some research, but just very, very cautiously with it on the radar to make sure you're not harming people and know what the flags are for that. But there, and we may learn out personality disorders were mentioned. We don't have great data. These are hard things to study. Sometimes you don't understand what personality disorders someone might have until you've been working with them for months. But things like borderline personality might turn out to be something that, if it's not handled well, especially, that it can end up making someone worse. Again, a lot of this is speculative because it's not like we have trials testing this or that. And so, yeah, and so people can become depressed. And then even within the session, there's actually, I did this interview, 60 Minutes did a piece on our work a few years ago, and they interviewed one of our cancer patients who described even within her session, she went through this period of just life is meaningless. And you get this in sessions, like, I thought it was going to be the opposite. Everything's great. It's like totally nihilistic. But even that within the session set the frame for her to then, like, her vision was like she was digging in this like barren, meaningless environment in the sand or the dirt, and then she actually found a tiny little gem, and then it like expanded, and then everything transformed. So it was almost like that experience of meaninglessness set up the conditions for her to feel the impact of meaning. I mean, it's a very philosophical, transcendental type of experience, because like it's the meaningless that defines the meaning, and so that's the kind of the direction she went with it. So yeah, you can leave the session and be stuck in meaninglessness. So this is and that's why, this is best done with therapeutic support for that. So I'm curious what others have to say. It's a big topic.
I think that really speaks to the importance of screening, to your point of some things that we know just maybe don't mix, or we don't have the research to know what's going to happen. We think it'll probably destabilize some folks, but also in that preparation / screening phase, managing people's expectations. So I kind of like alluded to this, magic wand, this is going to make everything better. I know a lot of folks that kind of contact me, that is what they're going in with. And that can be really tricky because I'm not going to say it's not going to happen, because I'm a psychedelic therapist. I never say anything can't happen, but it might not. And so often when I find people are really disappointed or are upset with the session that they had, or what did or didn't come up, it's often because expectations weren't properly managed going in. So that really can be a great conversation to have with someone beforehand.
Yeah, I would add in agreement with what's been said is that again, the paradigm's different and is not suppressing symptoms with medications on the daily basis. It's not like hiding them in the box and leaving them there with your daily intake, which it works for some, and it may be appropriate for some. However, the paradigm is you actually open the box, you dig through, you discover, you unearth things, you unbury, and you manifest. So there is potential for a bad trip, which is actually necessary in the process, in the arc of the process, for the person to then work with that energy or that content and then come out through the other side in a different way, such that they don't manifest the same symptoms. So that's the change and the transformation. So you could get worse before you get better. You could get destabilized before you get better. I have patients that come in after a few sessions and they say, this is working with legal ketamine, in ketamine-assisted psychotherapy, is I expected to be better. I expected that this was gonna, fix me. And my answer is usually, you are right where you need to be. This is working. It's hard. And it's because we are opening this big box. Everything you've buried, everything you're denying, unconscious and consciously, is psychologically is what will get you to, hopefully, with appropriate care, support, process, to the other side. It's not an easy process. It's difficult. It's not always rainbows. And so as long as a person continues support and there's a commitment to that process, then I think that's the difference in this paradigm, that sometimes you could get worse and maybe abort treatment prematurely before getting better.
And that's a wonderful point, and we see that all the time. And that's just also to connect that to another point about this essentially being psychotherapeutic process when this works. That's exactly true, totally outside of psychedelics, for good psychotherapy, particularly when we're talking about trauma and other anxiety, really all the anxiety disorders. Like, the things that we know work are difficult. And sometimes in the short term, things become more difficult because it's actually working with that material, with the issues that are difficult. And, before then they're resolved to get better. So it's completely consistent with psychotherapeutic science more generally.
And it goes against everything we've been taught. Sorry, Tasha, to your point about not being able to, or told not to feel, like, we actually teach people, if you don't feel anything, that means you're better. And so sometimes it is that reframing to what's been said, like, that does not actually mean you're better. And it might be really uncomfortable and difficult, but that doesn't necessarily mean you're worse, or it didn't work, or you're broken. It might be you're coming around to the other side. So yeah.
I was just going to jump in and say, thank you all for all the important themes you're touching on here. And I think this theme of managing expectations is super crucial. And it touches on another question that we've seen coming up in the chat, which is a question about the training process for licensed facilitators. And I think the connection there is that we do want to make sure that that is robustly addressed in training, how to talk about this in a way that doesn't necessarily like influence the experience itself, but helps set somebody up to understand some of these complex dynamics. And so to answer that question just briefly, the specific requirements of training are still in process, but actually our third session of this series is going to be specifically focused on training for facilitators. So I really encourage you to join us for that. It's going to be, I believe, February 28th, and we will have more of an idea then of what they're looking at and specifically the requirements for training. And we'll also, and I'm excited about this, get to hear from people in Oregon who have gone through the training programs there and are now practicing in the world's first legal model for psilocybin therapy at the state level. So definitely come out to learn more there. All right, we just have a couple minutes left. So I know there's a lot of questions in the chat that unfortunately we are not going to be able to get to. I wish we could. But there is an important point that I wanted to raise while I still have a really large group of some of our clinical practitioners here in Colorado on the call, which is that in Colorado, we're going to allow psychedelic therapy or psilocybin therapies to occur at 3 location types. There's healing centers, there's approved healthcare locations. So that might include palliative care, addiction treatment, or clinics. And then the third one is at home, specifically in contexts like hospice, end of life, or when there's substantial barriers to somebody leaving their home. For the second one, we want to put this out there. It seems like the state needs to delve a little deeper in the questions around that. And so we are also trying to delve deeper in those questions. And just want to say, if you are somebody working in the healthcare profession in Colorado and you have ideas or thoughts about this, do please feel free to reach out to us after the call, because we'd love to engage in that conversation of how we can inform the process to best support safety and responsible access in those types of settings as well. So with that, I'm sorry to say that it's time to wrap up, and I just want to thank the 3 of you again for carving out the time to join us and just lending your incredible wisdom and expertise to this conversation and to this process. And we hope to remain in conversation with you as we all move forward.
Thank you so much. I appreciate it.
My pleasure. Thank you all.
Thank you.
Thank you. And for everyone listening in the audience, thanks for joining. And we do hope to see you on the next 3 installments of this series. Also, again, a huge shout out and thank you to Vincent and the Mental Health Colorado team for helping us pull this off. Really appreciate you all.
No, thank you all. What a great conversation and such great work that you're doing.